It is a privilege to be here talking today about a theme I am very passionate about, which is the use of patient-reported outcomes for monitoring progress of rehabilitation and measuring functional impairments in long COVID. I am Laura Tabikoff. I'm an assistant professor at the Department of Rehabilitation and Human Performance at Mount Sinai. So today's agenda, we will cover a bit of the background of the use of patient-reported outcomes in long COVID. We're going to discuss a few long COVID instruments. Then we're going to dive into patient-reported outcomes. I'm going to present some preliminary data of the use of these patient-reported outcomes on long COVID. And then we're going to talk about challenges and future directions. So unfortunately, to start talking about use of PROs in long COVID, we're going to have to take a step back and travel in time to May 2020. Around that time, our group at Mount Sinai was running a remote patient monitoring program for people with acute COVID infection. And around May 2020, we started to notice that a lot of people were exhibiting persistent symptoms and they were not getting discharged from the program as we were expecting. So 2 weeks, 3 weeks after their acute COVID infection, sometimes after a month, they were reporting fatigue, shortness of breath, intolerance to exercise, brain fog, and other symptoms. Some of them had a well-established cause for these symptoms. So some of these people were admitted to an ICU and they were developing post-intensive care syndrome, which is a well-documented entity. Some people had a severe lung impairment during their acute phase of their illness and were developing pulmonary fibrosis. Others were developing myocarditis, which was relatively common. Some people had acute kidney injury. But there was a group of about 10 to 15% that were developing these persistent symptoms, and there was no well-established cause for this. They were not admitted to the hospital. They were not intubated. They did not have any cardiovascular or pulmonary complications. So we started calling this group post-acute COVID syndrome or long COVID. Around that time, other groups around the world also started to identify the same phenomenon. And as part of the WHO Rehabilitation 2030 initiative, in June of 2020, the WHO summoned a working group of physiatrists, so rehabilitation physicians from different parts of the world to discuss a system and develop a system of longitudinal data collection for COVID-19. I was honored to participate in this group with colleagues from different continents, and we met weekly and discussed the main disability and rehabilitation aspects that should be measured for everyone developing long COVID symptoms. So this document is called the Global COVID-19 Case Report Form, or CRF, for post-COVID condition, and it is a clinical tool designed to document the sequelae of COVID, to identify mid and long-term clinical and rehab needs, and also to ultimately ensure that patients are getting proper care. So the first step in this group was to identify the 10 major symptoms that were being commonly affected in long COVID. So the symptoms identified are here on the left. So respiratory, cardiovascular, musculoskeletal, neurocognitive, renal, GI, and others as well. And the CRF, based on these systems, we developed the CRF using 3 modules. So the CRF is divided in 3 modules. The first module includes background demographic information and clinical information of the acute episode of COVID. So if the patient was hospitalized, what kind of a level of care they received. The second module includes questions to help identify patients who require further evaluation. And the third module includes a long list of medical assessments and patient-reported outcomes as well. So this is a mix of PROs and outcomes that are assessed by a clinician with the patient in person. And it is a very extensive list. So it includes the patient health questionnaire, the WHO disability assessment scale. I'm not going to dive too much into this now because we're going to cover a few of them. But this is just to show that the CRF includes some patient-reported outcomes. I think there's about 20 patient-reported outcomes included. and a lot of other exams or tests. So the mini mental, the MOCA, 6-minute walk test, hand grip, so to assess all systems. So the CRF is a publicly available document. It's available here on this website, and it is an extremely valuable tool, but is also, as I mentioned, extremely extensive. So it includes 11 pages of information, and it can potentially take hours to complete. At that time at Mount Sinai, when this was developed and published, we had limited clinical resources, and we also had hundreds of patients reaching out in need of medical care. And because the CRF was such an extensive document, we did not have the resources to physically evaluate all patients in a timely manner. So for that reason, we adapted the case record form and created a shorter online survey, which is fully patient reported and takes about 15 minutes to complete. We also found particularly important that it's a straightforward and not too much of a burdensome document, because a lot of people were reporting that cognitive exertion was exacerbating their long COVID symptoms, mainly fatigue. So we also wanted to be mindful of that and create something that would not burden these patients. So we use REDCap, which is our HIPAA-compliant data collection system at Mount Sinai, and this was sent to all patients who enrolled in our rehabilitation clinic. I'm going to dive in a little bit on our survey. So our survey includes 5 sections. So the first section is demographics. The reason why we have a demographic section is we wanted to explore patterns and ultimately ensure equity to access to health care and across different genders, ages, ethnicities. We also included a section with questions about acute COVID severity to identify other conditions that could be potentially happening, potential differential diagnoses associated with hospitalization, so PICS, pulmonary fibrosis, and others. We also included a symptom checklist to ultimately identify symptom clusters. And we included a section on patient-reported outcomes. The goal of the patient-reported outcomes section was to quantify degree of impairment and severity of symptoms, determine rehabilitation needs, and guide referrals to other rehabilitation sources, and also compare with other cohorts from other countries and cohorts that had different chronic conditions. We also included a section with questions about work, physical activity, and employment to quantify impairment and determine rehabilitation needs, and also gathered this data for policymakers and stakeholders, particularly about employment. So we're going to dive in a bit more on patient-reported outcomes now, my favorite topic. To assess respiratory symptoms and systems, we included the MRC breathlessness scale. To assess participation and quality of life, we included the EuroQoL EQ5D5L and the WHO Disability Assessment Scale short form with 12 questions. For the musculoskeletal system, we included the pain NRS 0 to 10, and also a self-reported Lance scale to identify if the pain had neuropathic origin or not. For the neurological system, we included the NeuroQoL cognitive function score. For mental health, we included PHQ-2 for depression, which is a depression screener, and the GAD-7 for anxiety. We included the fatigue severity scale for fatigue and the post-exertional malaise for post-exertional malaise symptoms, and also ME-CFS. And we also included other outcome measures, including the Epworth Sleepiness Scale, the COMPASS 31 for dysautonomia symptoms, and the SHS-GI for GI symptoms. And this was not sent to all patients, but to particular cohorts. I'm going to dive a bit into each outcome measure just to give an overview of the scoring system and the categories and the interpretation. So the breathlessness scale, the MRC breathlessness scale, categorizes in 5 different grades, where grades 3, 4, and 5 correspond to moderate to severely disabling breathlessness. And also I wanted to throw the references here in case anyone is interested. The EQ5D5L has been used by different groups to assess long COVID symptoms. It includes two parts. The first part includes 5 dimensions: mobility, self-care, usual activities, pain, discomfort, and anxiety, depression. And each dimension is rated in 5 levels, ranging from 1, no problems, to 5, severe or extreme problems, or unable to perform. And the second part is a health-related quality of life visual analog scale, ranging from 0, worst health imaginable, to 100, best health imaginable. So the scoring system is both categorical and a VAS. For the musculoskeletal system and for pain particularly, we included the numeric rating score, as I mentioned, 0 to 10, and also the self-reported LANS. The self-reported LANS scores equal or above 12 indicate likelihood of neuropathic origin. For the NeuroQual, one of the most important outcomes we used, it's a NeuroQual outcome measure. So the scoring system, you do a sum of all the scores and you convert that number into a T-score using this website. So they have a table where you can match a total score with a T-score. And then the interpretation is here below. For the fatigue severity score, there are 9 items scored on a 7-point Likert scale. You can do a sum or a median. There are 2 options. We like to do a median because there's an interpretation available of a cutoff score of 4 or more, considered indicative of problematic fatigue, which we think that is very helpful. The PHQ-2 is just a screener tool. So a score 3 or greater indicates likelihood of major depressive disorder. The GAD-7 includes 7 items scored on a 4-point Likert scale. The sum ranges from 0 to 21, and the interpretation is here below. For post-exertional malaise, also, we use this brief post-exertional malaise questionnaire. And we use this first section here where 2 on any items, 1 to 5, indicate likelihood of post-exertional malaise and or ME/CFS. And now I'm going to dive in a bit on preliminary data. So I'm going to present some data that was published by my team last year on the American Journal of PM&R. So this is a preliminary data set composed of 156 individuals referred to the Mount Sinai Center for Post-COVID Care. As we can see here, the majority of these individuals were female. They were relatively young, so mean age of 44. The vast majority, you can see here, was not hospitalized during the acute phase of their illness. So only 10% was hospitalized. Also important, about half of these people had confirmed COVID infection by a positive test, but they were considered as probable COVID infection by the WHO criteria. And this is really important because we were enrolling in our clinic a lot of people who were sick during February, March 2020. And at that time, access to tests was very limited. So we opted to be comprehensive and include people who did not have acute positive test, but were presenting clinical symptoms that were acceptable as COVID. We also see that COVID-related symptoms were often persisting for longer than 1 year, so a median of 351 days, which is a lot. The most common symptoms observed were fatigue, brain fog, headache, insomnia, dizziness, dyspnea, memory loss, and palpitations. Triggers of symptom exacerbation most commonly reported were physical exertion, stress, and dehydration. On patient-reported outcomes, more than half, so 63% of the patients scored for at least mild cognitive impairment on their NeuroQual cognitive function, and approximately 15% scored for severe impairment. Also, on the fatigue severity scale, 78% indicated debilitating fatigue, and also 40% were showing signs of debilitating dyspnea on the MRC dyspnea scale. So these patient-reported outcomes were really highlighting the severity of these symptoms in this population. We also quantified self-reported effects on physical function. So in this graph here, we can see levels of physical activity regularly completed by the participants, both moderate physical activity, such as walking, as well as vigorous, like running. And in dark gray, we see pre-COVID data. And in light gray, we see post-COVID data. And it's really clear the reduction in frequency in both moderate and vigorous physical activity. And this can potentially correlate with symptoms being exacerbated by physical activity, which is something that a lot of patients were reporting. But this data not only shows further evidence of impacts on function, but it also raises concerns about long-term health risks associated with physical inactivity. And potentially these symptoms were also impairing ability to work. So since the percentage of patients in full-time employment reduced from 76 pre-COVID to 41 post-COVID. And of course, this may be a reflection of the socioeconomic impacts of the pandemic. But when we look at the high percentage of people indicating they were unable to work due to their illness, as highlighted here in the graph, this suggests that this may be indeed evidence of post-COVID related disability, which is also alarming. So now I would like to dive a bit deeper on levels of fatigue, cognitive impairment, and disability. I'm presenting some unpublished analysis of the same survey, but on a larger sample size. So this was sent to 533 individuals referred to the Mount Sinai Center for Post-COVID Care for rehabilitation. Again, similar demographics. These people were mostly female. They were relatively young, so mean age of 46, and 90% were never hospitalized during acute illness. So they had mild or moderate acute illness. So on patient-reported outcomes, 81% had scores indicating severe fatigue. And the mean score of the group was 5.4 out of 7. And here on the table, we put this value in context with other conditions. So that's the importance of using patient-reported outcomes that are validated in different cohorts, because that allows comparison, which is really important. So we noticed that this level of fatigue is comparable to other post-viral syndromes, such as post-polio syndrome. And it is also more severe than levels of fatigue reported not only in the general population, which is somewhat expected, but also in other chronic neurological conditions, such as multiple sclerosis, Parkinson's, and epilepsy. So the great majority, 70%, indicated some level of cognitive dysfunction on the NeuroQoL, and 51% had scores indicating moderate to severe dysfunction, indicated here in orange and red in the graph. Again, putting this value in context, this 51% is substantially higher than what is seen in the normative population, which is about 20%, as we can see highlighted here. It is also important to consider that our cohort was generally younger than this normative population. So this difference may be even greater than what we see here. We also noticed that the NeuroQoL mean scores were also statistically lower when compared to reported normative population, emphasizing the magnitude of cognitive impairment in long COVID. Now looking at the EQ-5D-5L, I'm going to take a second here to explain this outcome. So as we mentioned, there are 5 components. So values in green to the left indicate no or slight problems. Yellow indicates moderate problems, and orange and red indicate severe or extreme problems, here more towards the right. So we notice that about half of the population, so we can see a cutoff line in the middle of the figure, had at least moderate problems with usual activities, pain, discomfort, and depression, anxiety. So indicating negative impacts on quality of life in multiple life domains. And now taking a quick look on anxiety and depression. So most people, 74%, indicated only minimal or mild anxiety. And looking at the table, here we also put that value in context with normative population to understand the severity of these domains in long COVID. On the depression scale, 31% scored positive for major depressive disorder. And although this is higher than what is expected in the general population, which is about 21%, we should also consider that 20% of these people indicated having baseline depression as part of their past medical history. The exact impact of depression in long COVID is difficult to estimate. We also were seeing alarming effects on function. So here we have the results from a question assessing impact of long COVID on employment status. So in yellow, we see that 1/3 of the participants indicated they were unable to work the same number of hours due to their health. And in red, we see that about 1/4 indicated they were unable to work at all due to their health, which is quite alarming. And we also included a question about disability. And of the 217 people who answered that question, 17 had applied to disability insurance, and only half of those were approved. And finally, on the WHO Disability Assessment Scale, or HUDAS, we see that more than half of the respondents reported some level of disability, and about 1/4 reported severe or extreme disability, displayed in red and orange again here. So this is just some preliminary data. We are running more comparative analysis, trying to see which of the outcome measures, which of the domains most impact employment and ability to function. But I just wanted to highlight that since launching our PRO survey, we collected data from over 1,200 patients. This data has contributed to multiple national and international projects, including WHO webinars to patients and clinicians about post-COVID rehabilitation. We also contributed to development of consensus guidance statements from the American Association of PM&R and Long COVID Physio. We also presented this data to the Social Security Administration and the National Academy of Sciences, highlighting the impacts on employment and disability and the use of patient-reported outcomes to diagnose disability in long COVID. Besides all of that, we also have published in respected journals such as the American Journal of PM&R, Cell. We also have a manuscript currently under review in Nature, part of our collaboration with a wonderful group working with Dr. Kiko Iwasaki at Yale. I talked a lot about the highlights of working with patient-reported outcomes, but I do want to emphasize that there are some challenges. So patient-reported outcomes are inherently subjective measures, of course, and they're also prone to different forms of bias, such as recall bias and interpretation bias. For instance, my interpretation of fatigue is likely different from yours, and we do see that happening, limiting our data. But I would argue that the major problem with patient-reported outcomes in long COVID is the heterogeneity of the data collection. So we see that different health systems, even on the same city, but also in different countries, each group will use their own metrics. Often these metrics are not validated. So this creates small, limited data sets that cannot be grouped together, which really limits our ability to draw stronger conclusions about the epidemiology and also the clinical presentation of long COVID to ultimately develop treatments. Thankfully, there are some groups doing the work to address this limitation. So the CRF by the WHO is an attempt to make this data more homogeneous. There was also this group who published this core outcome set for post-COVID, published on The Lancet. So this lists the major symptoms and life impact outcomes to be assessed in long COVID. Hopefully a step in the right direction of international consensus in data collection. In the last couple of months and probably last year, there were a couple of long COVID specific outcome measures that were developed as well. So the post-COVID functional status scale was published, and also the symptom burden questionnaire for long COVID is also a valuable tool published by the University of Birmingham. They're also, again, hopeful steps in the right direction. They do have some limitations, so there's limited data available for them. Obviously, they were developed a year ago. And also, we noticed that the symptom burden questionnaire is quite lengthy and is also not a great fit for our patient population. So hopeful steps in the right direction, but still more work to be done. Just wanted to lay out here the key messages from this presentation. So since there are no universal biomarkers for long COVID or long COVID related disability, diagnoses and quantification of impairment should be based on patient reported outcomes for now, as well as clinical evaluation always. Looking at the patient reported outcomes, we see that long COVID can reduce function and participation for longer than 12 months, despite severity of acute illness. We also know that impairments are comparable or even more severe than what is seen in other work debilitating conditions. So the debilitating impacts of long COVID are non-trivial and should be taken quite seriously. Clinicians should be trained to diagnose long COVID so we can determine its prevalence and also ensure that proper care is delivered. And finally, consistent data collection across medical systems is key and will ultimately contribute to our knowledge about long COVID and hopefully guide better treatment options. So just wanted to highlight a few of our efforts at the moment and our next steps forward. So again, hopefully we'll see more national and international consensus on data collection. Hopefully we'll be able to have more multi-centered and international collaborations. We already have a few in place where we compare data across different populations, which is really important. We also want to focus on development and validation of disease-specific outcome measures, and that will be really helpful to quantify long COVID-specific impairments and symptoms. Also, more work to be done on determining the best metrics to evaluate response to treatment, as well as the best parameters to be used as diagnostic or severity criteria. And something that we're very excited about and are already working on is to run a cross-analysis between PROs and objective biomarkers, including immunological signatures of long COVID. Cortisol levels is something that we're really interested in. Viral persistency, presence of microclots. These are just some projects that we currently have going on in our pipeline, but there are other objective biomarkers that should be cross-referenced with PROs. I just wanted to give a shout out to the wonderful team that I'm so thankful to have the opportunity to collaborate with. These are just a couple of names. Thank you for your time, and my email is here for any questions or comments.